The remainder of this lecture will be devoted to complications of deep space neck infections. All right, let's turn our attention now to the potential complications of deep space infections of the neck. Let's talk about peritonsillar abscess. In order to understand the location of a peritonsillar abscess, you need to know even more than we've already talked about the anatomy of the tonsils. So surrounding the tonsils is a capsule, a fibrous barrier to infection, and it's a pretty good barrier to infection that should keep things inside the palatine tonsils. Outside of that capsule is the lateral pharyngeal space. This is a potential space and normally contains nothing. It just keeps the capsule of the tonsil from rubbing too hard against the superior pharyngeal constrictor muscle, which is the next thing out laterally. If you get through the superior pharyngeal constrictor muscle, then you're out into the parapharyngeal space, the true parapharyngeal space, that is the parapharyngeal fat. One thing that's really important to understand about peritonsillar abscess is that the tonsillitis that initiated it may have resolved. The classic scenario is that a patient comes to the emergency department and complains of difficulty swallowing. They are diagnosed with acute tonsillitis. They're usually not imaged. They're diagnosed with an acute tonsillitis, and they are sent home with a course of antibiotics. They then return a week later, sometimes having not completed their entire course of antibiotics because they felt better, and that is when we diagnose the peritonsillar abscess. The acute tonsillitis has resolved, and that's when we find a peritonsillar abscess a week later. Now, why do we keep saying peritonsillar abscess instead of tonsillar abscess? Can't you get a true tonsillar abscess? Well, you can, but they're very rare. The reason that tonsillar abscesses are rare is, again, the anatomy of the tonsil. If you are inside the tonsillar parenchyma, you are never far from a mucosal surface because of the crypts of the tonsil that involute in and out and in and out. So you're always close to a mucosal surface. So it's very easy to autolyse any forming abscess into the oral cavity. And that's why it's hard to form a true tonsillar abscess. But they do come from time to time. This again is that picture of an acute tonsillitis, the serpentine pattern of enhancement in and out of the tonsillar crypts. There is no focal collection, just edematous parenchyma separating this enhancing mucosa. Acute tonsillitis. This is a peritonsillar abscess. Note that the tonsil itself doesn't look too bad. It's about the right size. It's been displaced by this large mass nearby, stretched out, but it's about the right size. It doesn't have abnormal enhancement. The tonsil itself doesn't look so bad, but underneath it, deep to the tonsil, is this mass with a thick enhancing wall, very dark centrally, spherical in configuration, a classic appearance of an abscess. This patient happens to have bilateral peritonsillar abscesses, which is actually quite rare. It's rare to get bilateral disease. Another potential complication of deep space infections is Ludwig's angina. In Ludwig's angina, there is an infection of the submandibular and submental spaces. It is important that all three of those spaces be involved, both of the two submandibular spaces and the submental space. If only one submandibular space is involved with the cellulitis, it's just not as worrisome, and we don't invoke the phrase Ludwig's angina. This tends to occur in males in their 3rd to 6th decade of life. The clinical presentation is a brawny induration of the submandibular and submental spaces, and trismus, meaning that the patient has difficulty opening his mouth. Ludwig's angina is a surgical emergency because this induration can push the tongue superiorly and posteriorly and close off the airway. So in Ludwig's angina, that's a phone call. If you say Ludwig's angina in your report, you'd better make a phone call to the emergency department, talk to the ENT surgeon, and let them know of the risk to the upper airway. In the original description, Dr. Ludwig did not describe abscesses, just cellulitis in the submental and submandibular spaces. However, we use his name even when we see some small areas of abscess, as in this case. You can see abscesses in the submandibular spaces bilaterally and inflammation extending centrally as well. So this is an example of Ludwig's angina. Another potential complication of deep space infections is Bezold's abscess. Bezold's abscess is a complication of mastoiditis. When you have a coalescent mastoiditis with confluence of the air cells, and you get cortical erosion of the mastoid tip, specifically the mastoid tip, you can have breakthrough of this infection down into the neck. The resulting abscess usually occurs in or around the sternocleidomastoid muscle, but can secondarily involve the masticator or parapharyngeal spaces. Here's that same image of coalescent mastoiditis. You can see breakdown of the septations between the mastoid air cells on the left, and in fact you can see the cortical breakthrough through the mastoid tip there that's going to be the source for our Bezold abscess. The same patient with images further down in the neck, you can see abscess forming within the sternocleidomastoid muscle, the muscle itself, markedly enlarged, extensive infiltration of the overlying skin and surrounding fat. Bezold's abscess. Another potential complication of deep space infection is involvement of the danger space. The danger space is one of the, quote, retropharyngeal spaces, and we'll talk about that in more detail. But the true retropharyngeal space only extends down to the level of T4, whereas the danger space extends all the way down to the diaphragm. What this means is that an infection that gains access to the danger space has the potential to spread all the way down to the diaphragm, causing mediastinitis, which tends to be even more dangerous than most of the deep neck infections we've been discussing. Now, it's worth noting here that the prevertebral fascia is tough. It's very difficult for an infection to get from the true retropharyngeal space into the spine, and it's very difficult for an infection to get from the spine into the retropharyngeal space. And that's why things like Pott's disease, the tuberculous infection of the spine, tends to be contained to the spine and surrounding musculature, whereas these bacterial infections that occur in the visceral space tend not to cause osteomyelitis of the spine or discitis. This drawing demonstrates the fascia of the neck, specifically the deep cervical fascia. In green is the investing layer of the deep cervical fascia, in yellow is the visceral layer of the deep cervical fascia, and in pink is the prevertebral layer of the deep cervical fascia, which splits anteriorly into a true prevertebral fascia and an alar fascia. And you can see that this provides us with 4 distinct spaces between the viscera and the spine. The visceral space, the true retropharyngeal space, the danger space of Holyoake and Gradinsky, and the true prevertebral space that includes the spinal column itself. This space in between the alar fascia and the true prevertebral fascia, this is the danger space. This is usually a potential space. There's nothing in it, and it only becomes important when infection that started in the retropharyngeal space or involved the retropharyngeal space spreads through the alar fascia into the danger space. Because this space can't reach the diaphragm, but this space can. Here's an example of a patient with an extensive infection of the deep spaces in the neck. You can see that there is an abscess starting to form in the retropharyngeal space, and there's abscess forming and infiltrating all around. This is such an extensive infection, you'd probably call it necrotizing fasciitis. But in any case, what's important here is the involvement of the retropharyngeal space. Now, we can't tell radiologically whether the danger space is involved just by looking at this one cut. The only thing we can say here is the danger space might be involved. There is abscess in the retropharyngeal spaces of the lower neck, and we need to be worried about mediastinal extension. Please get a chest CT with contrast to look for mediastinal abscess. So we don't say the danger space is involved. We say, let's get a chest CT and see if the danger space is involved. Of course, in this case it is, because I'm showing it as an example. Here is the abscess extending down into the mediastinum from the danger space into a mediastinal abscess. And if we're far enough down, there is actually abscess extending all the way to the level of the diaphragm. That is the full extent of the danger space. And that's the reason we get a chest CT in these circumstances. We will continue our discussion of complications of deep neck infections in the conclusion of the lecture, part 4.